Polycystic ovarian syndrome, also known as PCOS, is a condition that affects millions of women worldwide. It's one of the most common hormonal disorders of women of reproductive age, yet many people remain completely unaware of its complexities and its widespread impact. Over the next 3 episodes of the show, we'll be taking a comprehensive look into this condition with Dr. Mark and Sister Elise, and they are from the T Clinic. So, Mark and Elise, it's a big topic, and I think we have discussed before that the awareness around it is so limited or relative to what it should be. Mark, let's just start though with a clear idea of what PCOS is.
Michael, as you said, it's very common, and it's the most common cause of infertility in women. So it's an endocrine hormonal disorder of your ovaries. So the ovaries are responsible for creating eggs, and where the eggs mature, and then the eggs, we call that a follicle, the sac that it matures in. And when the egg needs to break out of this follicle, and then there's hormonal changes that drive this whole thing. So we have 4 hormones involved: follicle stimulating hormone, luteinizing hormone, and that leads to production of estrogen and progesterone. And it's a dysregulation of that system that then leads to polycystic ovarian disease.
Right.
It's complex, it's common, up to 27% on certain studies of women will have polycystic ovarian disease. It occurs from the age of about 15 to right through your reproductive years. But the biggest problem is that 70% of women with this condition is never diagnosed.
So
and it's something that's treatable or manageable at least.
Now, Elise, what are some of the risk factors that would be indicative of PCOS or lead to PCOS in women?
Okay, mostly genetics. Genetics is the biggest role. If your mother had it, you will most probably have the condition. And then also hormone imbalances. That's the biggest risk factors at this stage. Yeah.
Insulin resistance is a very, very big driver of this, and inflammation. Now, we have spoken so often about insulin resistance and metabolic disease as the drivers of inflammatory conditions. And this leads to that. All of those, Michael, create a dysregulation in the hormones. So we can think of polycystic ovarian disease as a condition where we have excess male hormones. Now, there's a lot that affects this. Your inflammation leads to more production of the male hormones. We call them androgens. So it's not only testosterone, it's DHEA, DHEAS, androstenedione, androstenediol, and some of them are active and produced in our adrenal glands, some of them are produced in our ovaries, but the majority of it is actually produced outside of the reproductive organs, in the skin and in fatty tissue. So when there's metabolic dysregulation, these hormones start increasing, and it leads to a condition where the ovaries cannot mature the eggs, so they don't burst out of the follicle. So we call it anovulation. Am I right, Sister?
That's correct, yes.
And Elise, why is it so important that we have to recognize or diagnose this condition? Because as Mark said, so frequently it's undiagnosed or unrecognized. What difference does it make if we know what we're working with to manage it?
The difference is you can prevent future diseases. For instance, diabetes, cardiovascular disease, high blood pressure. The basic things that these women present with is most probably acne because of the overproduction of oil in the skin because of the androgen production. Hair growth, on the stomach and
so
the unusual places, as well as the insulin resistance is exacerbated with this condition. So they gain weight, and depression is one of the big things as well. All of this is so interlinked with each other.
So it becomes a huge lifestyle inconvenience, maybe, if I can call it that, because ladies are then dealing with a lot of other things that are going to cause further depression. So Mark, how is this diagnosed? Because you say it's underdiagnosed.
Michael, before we go to the diagnosis, there's two consequences that we need to understand, which Elise hasn't mentioned. The first one is there's a far higher incidence of endometrial carcinoma later on in life. So if we just take a look at the uterus, the inner lining is called the endometrium. And that is what needs to thicken under hormonal influences for implantation of a fertilized egg.
Right.
Now, if there's no fertilization, that lining breaks down and it's shed, and that gives you your monthly period. It happens under the effect of the hormones that we mentioned earlier. Now, there needs to be a tipping point. You have to have enough progesterone for that to take place. But because there's dysregulation, you don't get enough progesterone, but you still have the effect of low levels of progesterone as well as estrogen, which makes this endometrium get bigger and bigger. And because you don't menstruate regularly, now this thickening starts changing, and your risk for cancer, endometrial cancer, starts increasing.
Right.
So it's really something that we need to take into consideration. And the other one, women who have polycystic ovarian disease and that are overweight have a 10 times higher incidence of sleep apnea. And so often we've spoken about sleep apnea on Real Health. So it really, really is something that we need to be aware of. It's really simple to diagnose polycystic ovarian disease. You need two of the three following symptoms. So the first one is you need to have irregular or absent periods.
Okay.
And we really start thinking about them if you have less than 8 a year. The second one is you have signs or proven elevated levels of androgens, the male hormones.
Okay.
So the signs will include, as Sister Elise said, the excess hair growth, the male characteristic, we call that virilization. Hair growth is called hirsutism. So acne, now we start wondering, add to that weight gain, and you know what, we almost condense. And the last one is there's more follicles, these little fluid-filled sacs in the ovaries that do not mature.
Right.
So you can make a diagnosis on clinical history, and that's what I want to bring across in these talks today, is that this can be managed and treated in primary healthcare institutions. You don't need fancy, expensive blood tests and sonars and scans and stuff. If a history is there of irregular periods with the signs of weight gain, insulin resistance, excess hair growth, acne, you basically have a diagnosis. You just need 2 out of those 3.
Okay. So we are unfortunately out of time for this discussion, but as we said, we are going to be carrying on this topic for a couple of episodes. Mark, somebody who may want to get a little bit of information, recognizes some of these symptoms perhaps, where can they find you?
The easiest is to call us at our rooms here in Johannesburg, 010-824-1393. We are available on social media, and our website is www.thetclinic.com.
Wonderful. We'll see you both back next week. So thank you so much for getting this discussion out in the open. A good start, I think. Well done.
Thank you, Michael.
Cool.